Good evening. Welcome you all to yet another episode of FCPI. I'm Swati. I'll be the moderator of the day. So, the topic of the day is infection control bundles, and it's my pleasure indeed to welcome the speaker for the day. So, today we have with us Dr. Anusha Gobinathan. She's a professor, Department of Microbiology and Quality Manager of Molecular Diagnostic Center at SRM Hospital, Chennai. She was awarded the degree Certified Infection Control Professional by CAHO. She has around 33 national and international publications, 3 patents, and 1 patent grant to her credit. Over to you, ma'am.
Thank you, Swati, for that introduction. Dear viewers, I'm really happy to present this topic. And infection control is one of my passion in microbiology. So I'm really glad that we could discuss on this topic. So let me share my screen. Okay. Swati, is the screen visible?
Yes, ma'am, the screen is visible.
Yeah. Today's topic is infection control bundles. So this is my intro. So if you have any doubts, you can mail me or you can WhatsApp me in this number, or you can get me through FCPI. So I'll be glad to answer your questions. Today's session will go through these headings. So we'll be talking about what is infection control bundle and what are the types of hospital acquired infections and the four main bundles, care bundles to prevent the hospital acquired infections. First of all, what is infection control bundle? Infection control bundle, it is a collection of evidence-based practices. And why do we need to implement it? So that we are able to improve the patient outcome. Okay. Now, evidence-based practices are actually collated by SHIA and by IDSA. And today I'll be telling the guidelines by IDSA. This is the care bundles in nutshell. What it covers as such is the four important hospital-acquired infection, namely catheter-associated urinary tract infection, central line-associated bloodstream infection, ventilator-associated event, and surgical site infection. So if you see this picture, now it shows there are 5 or 6 points under each of the care bundle. Okay, so let's not go into the details right now. I'll be discussing that individually under each heading. But this is how it looks like. A care bundle looks like this. And you have two types of checklist. One is the insertion checklist. The second one is the daily assessment checklist. Okay. So there'll be minor variations between the two. So this we will see as we go ahead in the topic. So before we go to infection control bundle, what is emphasized in each of the care bundle is hand hygiene. Hand hygiene is one of the most important step to prevent any hospital acquired infection. And there are 5 moments of hand hygiene, that is before patient contact, before performing any aseptic procedure, be it IV insertion or anything for that matter, and after body fluid exposure, after touching the patient, and the fifth one, which is most commonly forgotten, that is after touching the patient surrounding. So this could be the patient's file, patient's rails, the monitor of the patient, the computer which is attached to the patient's, the various equipments which shows his vitals. So it could be anything. So hand hygiene is important even after coming in contact with patient surroundings. So let's go to the first one, the first topic, that is central line associated bloodstream infection. Before we go into the care bundle for CLABSI, it is important we understand what is central line. So what is central line? It is nothing but a line which is placed in one of the most important venous system or arteries in our body. Okay, and whenever we talk about CLABSI, okay, there is a concept called as eligible central line. So, a central line that has been in place for more than 2 consecutive calendar days, that comes under eligible central line. Okay, so only such central lines are included in CLABSI. And generally, eligible central line applies for an inpatient because we expect CLABSI to occur in an inpatient, and it has to be the current admission, okay, not the previous admission. So this is a picture of a central line, and you can see that a subclavian vein is the line is inserted into the subclavian vein. Now coming to what are central lines, okay, because we have various arteries and veins in our body. Now what constitutes the central line? So central line is an intravascular catheter that terminates at or close to the heart, okay, or it is in one of the great vessels. So if you have a catheter, intravascular catheter in the aorta, pulmonary artery, SVC, IVC, bronchocephalic veins, internal jugular veins, subclavian veins, external iliac veins, common iliac veins, femoral veins, or umbilical artery or vein, it is constituted as a central line. What are not central lines? So arterial catheters, AV fistulas, arteriovenous grafts, atrial catheters, ECMO, intra-aortic balloon pumps, peripheral IV lines, ventricular assist device. These are not considered as central lines. Okay. Now, there are two terms which are quite confused with each other. Okay, there is CLAPSI and there is CRBSI. What we need to understand in the perspective of hospital-acquired infection is, for surveillance basis, what I say, the definition which comes under for surveillance is CLAPSI. Whereas when you diagnose a patient, the term what you use is CRBSI, where CRBSI actually refers to catheter-related bloodstream infection. Okay. Now, CLAPSI is just a surveillance tool. So you do not treat the patient based on CLAPSI. Whereas if the patient is diagnosed with CRBSI, you have to initiate treatment. And there are certain guidelines how you will diagnose whether it is CLAPSI or CRBSI. So when you come to the microbiology lab, we do a quantitative culture for diagnosing CRBSI or a differential time to positivity. Okay, so I will not go into it because it's more microbiology in that concept. So we use that for CRBSI. Whereas for CLAPSI, it's just a qualitative blood culture. So what bacteria has grown in the blood culture? You don't quantitate it. You do not find the number of colony counts of that particular bacteria. So what is the advantage of doing CLAPSI? It has lower costs when compared to CRBSI and it is convenient. Okay. But the disadvantage is it does not differentiate between primary bloodstream infection and a secondary bloodstream infection. So what is a primary bloodstream infection? So it is an infection which is originated, okay, which has directly stemmed into the blood for the first time. Now, the secondary bloodstream infection is, for example, if you have an abscess in some part of the body, and from the abscess, the bacteria has leaked into your blood. That is called as secondary bloodstream infection. For a primary bloodstream infection, let's say a good example will be typhoid fever. Okay, so that is primary bacteremia. Okay. Right. So in today's concept, we are only worried about CLAPSI. We are not going into CRBSI. So to understand how to prevent, okay, or to understand the bundle for CLAPSI, we have to know what are the sources of infection of CLAPSI. So how can this bacteria enter into the blood? So either when you have the skin is colonized with the bacteria, and when you did not use aseptic procedure to insert the central line, the bacteria which was there on the skin has entered through the catheter into the bloodstream. So that is one way of the bacteria entering into the bloodstream. Number two is hematogenous seeding. Okay, that is already inside your bloodstream. You have the bacteria, so that has seeded the catheter. Number three is intraluminal contamination. That is inside the lumen of the catheter, the bacteria is present. So there is some contamination and that is leaking into the bloodstream. Number four is infusate contamination. So the central line is inserted to either administer fluid or medications. So whatever you're administering, if that has contamination, then through that contaminated fluid or medication, the bacteria has entered into the bloodstream. So these are the four ways how a person can get CLAPSI, either because of organisms present on his flora or because already there was hematogenous seeding of his bloodstream, or inside the lumen of the catheter there was bacteria, or the infusate which was attached to the central line, okay, the fluid or the medication which was passed into the central line had contamination. Okay. So this is the guidelines we'll be following today for all the four care bundles. That is the IDSA guideline. And for CLAPSI, it is the 2022 update. So in the IDSA guidelines, so there are various headings, okay, under which they discuss the prevention for CLAPSI. The first one is before insertion. So what should you do before inserting a central line? So the person who's inserting the central line or the team which is involved in insertion of the central line must be trained adequately, okay? And if you're inserting the central line for a patient, for an ICU patient who is aged more than 2 months, then you must have given a chlorhexidine preparation to the patient, okay, on a daily basis. Next is during insertion. So during insertion, what you should follow. So first thing is the bundle checklist, which I'll show you after the next few slides. So you have to adhere to the bundle checklist, that is the insertion bundle checklist for the central line. Then always perform hand hygiene before inserting the central line. The subclavian site is the most preferred site for central line. So this is something which is very important. You have to know that the subclavian line is a preferred site. No other central line is the first priority for inserting the central line. Then the person should be wearing PPE. He should be he should be following sterile barrier precautions when he is when he is inserting the central venous catheter. And a cart should be present where it includes all the necessary items which are required during the CVC insertion. So it should not be like he has started to insert the central line and suddenly he requires something and somebody has to run for it. So there should be a allocated catheter cart next to this person, and there should be a nurse or somebody to assist the doctor for inserting the CVC. Okay. And it is preferred that the doctor uses an ultrasound, okay, so that it will guide him easily to insert the central venous catheter. And always before inserting the central venous catheter, the skin has to be prepared using chlorhexidine. Okay, so these are the guidelines to be followed during insertion. So this is the insertion checklist. So hand hygiene must be performed. Is the doctor and the people involved in the team of CVC insertion wearing gown, gloves, mask, etc. Is the skin of the person prepared with chlorhexidine? Okay, the patient's skin has to be prepared with chlorhexidine. Is the optimal site selected? And the optimal site is always the subclavian. Only for some reason, if you do not have access to subclavian, then the other veins can be chosen. Okay, the jugular vein. So, and as soon as the CVC is inserted on the catheter, you have to document the date and the time. Okay, so it has to be labeled, and an antiseptic dressing must be done. So this is the insertion bundle of the central line. Then you have daily assessment of the central line. So what are the daily assessments? So every day the nurse who is looking after that particular patient who has the CVC should check the following things. Okay. So what should she check? She should, first of all, before she touches the central line, she should make sure that she is using hand rub. So hand hygiene must be maintained. Number two, daily assessment for continuation. That is the central line actually required for the patient? So usually central line is put for administering fluid or medication. Now, if that is not required, then the nurse should ask the concerned consultant whether actually it is required to continue the CVC. So that is the second point in the checklist. So daily assessment for continuation. The third thing is if the dressing is wet, okay, so or it is soiled, then that has to be replaced. And number four, assess the catheters only with sterile devices. That is, if you're going to assess the catheter with a syringe, the syringe has to be sterile. And when you're inserting any medication into the port, you have to scrub the access port, okay, prior to using it. And this can be chlorhexidine. And every day the nurse has to check for any sign of infection on that particular area. So this could be redness, or it could be whether there is any discharge over there, any swelling there. So if at all anything she sees this, she has to inform the concerned consultant because the central line will have to be removed in that particular case. Okay. And another thing is she has to make sure that she has to know how to do the surveillance for CLABSI in the ICU setting. And if the blood culture has come positive, then she'll have to check whether the blood culture actually fits under CLABSI. Okay. And also the necessity of the catheter, okay, has to be verified every day, whether it is absolutely required to have the catheter every day, and the readiness to remove. So that has to be documented. So every day you have to check for readiness to remove, and that has to be documented. If it is no, that has to be documented. So this is the daily assessment checklist for central venous catheter. Okay, so insertion bundle along with the daily assessment, this forms the infection control bundle for CLABSI. So after insertion, now what should you do? So after insertion, some of the points we already discussed in the daily assessment. So you can do the various things which I had highlighted in the daily assessment checklist only if you have an appropriate nurse to patient ratio. Okay, so if you have a floating nurse population, this will not be possible. So a nurse has to be allocated to the ICU patient. Only then every day she can check whether there are any signs of infection. She can assess for readiness of removal. Okay, so all these things can be done only if there is an appropriate nurse to patient ratio in the ICU. And generally use only chloroxidine contained dressings for CVCs, especially if the patient is more than 2 months of age. Okay, and there is a concept of changing the dressing. Now, this varies if it's a gauze dressing and a transparent dressing. If it's a gauze dressing, the dressing has to be changed every 2 days. Okay, or within 2 days, if the dressing is soiled, then immediately it has to be changed. But in the case of transparent dressing, okay, it has to be changed after 7 days. So that is the difference between transparent dressing and the gauze dressing. Next thing is always disinfect the catheter hub. It is very important to disinfect the catheter hub before you insert a syringe or administer any medication. And suppose the central line has been inserted, okay, for giving the patient any blood products or giving the patient any parenteral nutrition, then the administration sets, okay, should be changed after 7 days. And if there is any non-essential catheter, suppose the patient has a central venous catheter, and the nurse thinks that it is not essential, then she should inform the consultant and ask his assessment for removal of the catheter. Okay. And, and always all the healthcare workers involved in the ICU should know how to perform surveillance for CLABSI. It's very important. So these are the points to be taken care after insertion of the CVC. Okay. Now, what are the additional approaches mentioned by IDSA to prevent CLABSI? One is in the case of high-risk situations, you can use antibiotic or antiseptic impregnated catheters. For long-term CVCs, you can use antimicrobial lock solutions. Okay, and suppose the patient is a patient who's undergoing hemodialysis. Okay, then you can give the patient recombinant tissue plasminogen activating factor, and always use antimicrobial ointments if it is a hemodialysis catheter insertion site. Okay, and use antiseptic containing hub if it is possible. Okay, so that will reduce the rates of CLABSI. So these are the additional approaches which can be followed to prevent CLABSI. Now, what are the things which is not recommended, okay, as a part of CLABSI prevention? Never administer antimicrobial prophylaxis, thinking that it will prevent CLABSI, okay, especially for short-term duration catheters or tunnel catheters. And there is no concept of routinely replacing CVC. Only dressing is changed after 2 days or 7 days, depending on whether it is gauze dressing or transparent dressing. But there is no concept of routinely replacing central venous catheters or arterial catheters. So that must not be done. Okay. Right. So with that, we come to the end of CLABSI care bundle. I hope it was clear. Now moving on to ventilator associated event. Okay. So in ventilator associated event, now we have three things. One is ventilator associated condition. And then next, when you have IVAC, there is inflammation along with ventilator associated condition, then you will have to evaluate the patient whether the patient is going to VAP. Okay. Now, what is the pathogenesis of VAP or ventilator associated pneumonia? Now, the common sources of ventilator associated pneumonia, if you see a patient who's in the ICU was developed VAP, either he's developed VAP because of aspiration, okay? Otherwise, it is because of the biofilm which was there in the ET tube or the secretions, because of the secretions which was present, okay? After ET tube insertion, there'll be some secretions which are produced. So, contamination of those secretions can cause, or contaminated respiratory equipment. So, all these things can cause VAP, right? Same thing is mentioned here. So if you have a gastric or a oropharyngeal or a subglottic bacterial colonization, that can be aspirated and cause pneumonia. And what are the risk factors for each of them? Now, for example, for subglottic bacterial colonization, the risk factor is if the person is malnourished, okay, he has prior antimicrobials or he has had a nasal intubation. So these are the risk factors for subglottic or oropharyngeal bacterial colonization. If the patient is in a supine position, okay, then he has more chances of aspirating, okay, the secretions and developing pneumonia. And when the person's immune system is very compromised and he has diminished defense mechanism, lower respiratory tract mechanisms, then he has more chances of landing up with pneumonia. Okay. Now, what are the SHIA guidelines? So, this is again the 2022 guidelines for preventing VAE, ventilator associated events, or more appropriately to prevent ventilator associated pneumonia. So they mentioned some essential strategies. Now, what are the essential strategies? The first thing is try to avoid intubation as much as possible. If intubated, try to remove the tube as early as possible and try not to reinsert. Okay, so prevent reintubation. So sometimes we will intubate and we'll think that it is not required and extubate, and then immediately in a 2 days we will be reintubating. So that has to be prevented. So avoid intubation. If you have intubated, okay, see that there is no condition created for reintubation. So what you can use in this particular case is, if you think that intubation is not required, you can use actually non-invasive positive pressure ventilation. Okay. Number two is minimize sedation. Okay. And number three is maintain and improve the physical conditioning of the patient. Elevate the head end of the bed to 30 to 45 degree. And the present guidelines advises that oral care has to be given with toothbrushing and not with chlorhexidine, and provide early enteral nutrition. Try for early enteral nutrition. And the ventilator circuit, there is a small picture in this slide of the ventilator circuit. The ventilator circuit has to be changed only if it is visibly soiled or if it is malfunctioning. Otherwise, routine change of ventilator circuit is not advised. Okay. What are the additional approaches to prevent ventilator associated pneumonia? One is you can use selective oral or digestive decontamination. Okay. Or you can utilize ET tubes with subglottic secretion drainage ports. Okay. Now, this is especially advised if you think that the person is going to be under ventilator for more than 2 days to 3 days. And if suppose you think that the person needs ventilator for a longer time, consider early tracheostomy, and always prefer post-pyloric feeding for the patients, okay? Especially for patients with gastric intolerance, so that it does not aspirate. So post-pyloric is better than gastric feeding for patients who have gastric intolerance. What is not recommended in the prevention list for ventilator associated pneumonia is oral care with chlorhexidine is not advised anymore. Probiotics, use of ultra thin polyurethane in endotracheal tube cuffs, tapered endotracheal tube cuffs, and there was a system of automated control of endotracheal tube cuff pressure, so that is also not required. Frequent cuff pressure monitoring is also not recommended these days. Silver coated endotracheal tubes, kinetic beds, all these things are not advised, okay, for preventing ventilator associated pneumonia. So there are a lot of updates which has happened here. So these are not recommended. Prone positioning, chlorhexidine bathing. If you remember, stress ulcer prophylaxis, this is still there in many of our hospitals in the care bundle, but it is not advised anymore. Monitoring residual gastric volumes, early parenteral nutrition, all these things are not recommended. Okay, they are not necessary in the care bundle for ventilator associated pneumonia. And there is no recommendation according to IDSA about closed endotracheal suctioning systems. Okay, so they do not have any recommendation for this. Now, this is an example of a ventilator associated event or a VAP care bundle. Okay, so if you see here, though IDSA says that stress ulcer prophylaxis is not required, cuff pressure is not required to be monitored, many of the hospitals still follow this. Okay, but it is better to be updated to the IDSA guidelines. So if you see this care bundle, you will see the first thing always is hand hygiene, head and elevation of 30 to 45 degree, oral hygiene with toothbrushing. If you remember, I said chlorhexidine is not advised by IDSA anymore. So please do not mention chlorhexidine. Cuff pressure monitoring is not required, so you can ignore point 4. Deep vein prophylaxis can be given. Peptic ulcer prophylaxis can be given, but stress ulcer prophylaxis is not required anymore. And here also they check for ventilator circuit, whether it is soiled or whether it is malfunctioning in every shift. Okay, and is early tracheostomy required for the patients? That is checked. Then sedation minimization, whether it is being practiced, that is checked. And readiness to extubate, that is very important to check every day. Okay, then suctioning of oral secretions, and is the patient having fluid overload? So what we must understand is the care bundle is different for every hospital. Okay, it is not the same. So we can prioritize our care bundle depending on our infection control teams, inputs and the inputs of the administration. So this is not the picture what I've shown is just an example. So you can improvise it according to your hospital setting. Now, coming on to the third hospital-acquired infection, that is surgical site infection. As we know, there are three types of surgical site infection. That is the superficial or incisional surgical site infection, which involves only the skin and subcutaneous tissue. Then you have the deep incisional surgical site infection, which involves the deep soft tissue. And finally, you have the organ space surgical site infection. Okay, and surgical site infection has very particular, symptoms or signs, so which is very evident, and it's very rare that we miss these signs of surgical site infection. So we will discuss this as we go through the slides. Again, IDSA has given guidelines for these update in 2022. Now, what are the essential practices which has to be followed according to IDSA? Administering antimicrobial prophylaxis is very, very important for surgical site infection. If you have noticed, antimicrobial prophylaxis is not recommended for CLABSI or for COTI or for your ventilator-associated pneumonia, but it is necessary for preventing surgical site infection, and it should be administered within 1 hour of incision. Okay. Now, you can use a combination of parenteral or and oral antimicrobial prophylaxis prior to a colorectal surgery. And generally, if you see, antimicrobial prophylaxis will be cefuroxime or cefazolin. Now, in the case of patients who are undergoing orthopedic or cardiothoracic procedures, you can use an anti-staphylococcal agent, okay, for decolonizing surgical patients. And also, in the case of patients who are undergoing cesarean delivery or hysterectomy, you can use an antiseptic containing pre-operative vaginal preparation agents. Okay, and we know that hair should be clipped, but what they say is do not remove a hair in the operative site unless it's going to interfere with the procedure. Okay, so that is one more recommendation what they are suggesting in the recent IDSA update. And use alcohol containing preoperative skin preparatory agents, okay, in combination with antiseptic when you're cleaning the area, preparing the area. And if the procedure does not require hypothermia, then you must maintain the patient in normothermia, okay, that is around 37 degrees centigrade. And after surgery, please use impervious plastic wound protectors, especially for gastrointestinal and biliary tract surgery. And perform intraoperative antiseptic wound lavage if it is indicated. And blood sugar must be controlled, okay, during the immediate postoperative period. Even intraoperative period, it has to be controlled. So blood sugar has to be controlled. So these are some of the essential guidelines told by IDSA to prevent surgical site infection. And if you see about antimicrobial prophylaxis, what they enforce is the correct antibiotic should be chosen for the surgery. Okay, so each surgery, specific antibiotic has to be chosen. Generally, the antibiotic will be a second generation cephalosporin, but for some rare cases, okay, the antibiotic varies. Okay, like for example, in certain surgeries, you prefer vancomycin. So correct antibiotic has to be chosen for the specific surgery. The correct dose has to be given, and the administration should be within 1 hour of incision. But in the case of vancomycin, 2 hours is allowed. 2 hours is allowed in the case of vancomycin and fluoroquinolones. Okay, and discontinuation of this agent after skin closure. So this is also important. So this has to be followed for the case of antimicrobial prophylaxis. Okay. Now, what are the additional approaches? Always we have to perform whether the person has a chance or has a risk for developing surgical site infection, and consider using negative pressure dressing, okay, in patients who may benefit from it. And always observe and review the practices which are happening in the pre-operative area, post anesthetic care area, in the surgical intensive care unit, and in the ward, okay, so that these practices do not lead to SSI. And if possible, use an antiseptic impregnated suture to prevent surgical site infection. What is not recommended, do not routinely use vancomycin for antimicrobial prophylaxis. So vancomycin should only be used if indicated. And do not routinely delay surgery just to give the patient parenteral nutrition. And it is not required to use antiseptic drapes. Drapes are those coverings what we use for the patient in the surgery. So it is not required to use antiseptic drapes as one of the strategy to prevent surgical site infection. Now, this is an example of a surgical site care bundle. Okay, so as I said previously, you can improvise it according to your hospital. Now, if you see in this, okay, pre-op, they are checking whether the patient's hair has been removed, that too with the clipper. And if you remember in the IDSA guidelines, they had said that if it is not going to interfere with the surgery, you needn't remove the hair. Okay, then they check whether the person has been given a surgical bathing, okay, with chlorhexidine, and if the patient's blood sugar is maintained. Okay, and any infection is present at the time of surgery. So this is done pre-op. Then inside the theater, okay, it is checked whether the perioperative temperature is within 18 to 21 degrees centigrade. That is the room temperature. Whether the humidity level of that particular room, the theater is 40 to 60 degree, 60 percentage. So these are all optional, okay? You can add or you can delete. Now, this is important, whether antibiotic prophylaxis is given 60 minutes before incision, whether surgical hand wash was done, whether surgical site preparation was done with appropriate disinfectant, and perioperatively, whether the patient's SpO2 is more than 94%, whether the person is in normothermia, whether his blood glucose is maintaining. Okay, so all this is checked. Okay, and if a repeat dose of antibiotic is given, sometimes people have a lot of blood loss. Okay, or the duration of the surgery becomes very long. So in that case, what happens? A repeat dose of antibiotic is given. So in that case, you have to document the time of the repeat dose. Then every day you will have to check whether the dressing is soaked, whether the wound is gaping, whether there is any discharge or pus from the surgical site, any swelling is present, any pain or tenderness is present, or fever is present for the patient, because these are signs of infection. So this is assessed in every shift. And also, if any antibiotic is administered, the details of the antibiotic is also mentioned. Okay, so this is an example for a surgical site care bundle. Coming to our last hospital acquired infection, that is COTI, catheter-associated urinary tract infection. Now, what is COTI is, see, after you have inserted catheter to a patient, after 48 hours of insertion, if the person develops UTI, okay, be it symptomatic or asymptomatic, okay, asymptomatic bacteremic UTI, that comes under COTI, that is catheter-associated urinary tract infection. Now, coming to COTI, so what is very important to prevent COTI is, number one is you try to avoid catheter use as much as possible. So there should be an indication for placing the catheter. So if there is an indication for placing the catheter must be inserted using aseptic procedure. Okay, and it should not cause a lot of trauma to the patient. So the proper diameter should be chosen for the catheter according to the patient. Now, next thing is the catheter, the entire system of the catheter has to be a closed system. Always hand hygiene should be maintained while inserting or while maintaining the catheter. And the catheter has to be secured. Usually, if you see, the catheter will be secured into the thigh of the patient. So, securing the catheter is very important so that the catheter is not pulled as the patient is moving. Okay, and what we need to avoid in this particular stage is, if the patient does not have any, you don't suspect UTI in the patient, there is no indication for checking the urine for bacteriuria. Okay, so do not do that. And remove catheter whenever it is not required. Okay, so you have to have catheter reminders to check whether actually catheter is required for the patient. Okay, and try doing early voiding trials so that the catheter can be removed easily. Okay, right. Now, what happens when the patient has urinary catheter is, usually it causes catheter-associated bacteriuria if kept for a very prolonged time. And once the person has COTI, okay, so this can end up into, the bacteria can seed into the blood and cause bacteremia. And it can also ascend up and affect the upper urinary tract. So the kidneys can also get affected. And whenever when we insert catheter, if we do not do it appropriately, if we do not use the correct size of the catheter, trauma will occur to the patient. So this urethral trauma will cause him discomfort, and this can in turn have cause UTI. Okay, right? So again, a lot of problems can be avoided if appropriate catheter is chosen for the patient. And when urinary catheter is there, usually the person is not in a mobile. What to say? He's usually he is limited to his bed. So this can cause more chance for venous thromboembolism because he can develop DVT. Okay, so there is more chance of thromboembolism. There is more chance of developing pressure ulcers. Okay, because he is immobilized, right? And so all these unwanted problems can occur because of duration of using the urinary catheter. So according to the 2022 update of IDSA, now what are the essential practices? Number one, insert urinary catheter only when necessary for the patient. Okay, and if suppose urinary catheter is not advised for the patient, then you can use other methods like intermittent catheterization. That is, in and out catheter can be used. And when catheter is being inserted, always follow appropriate technique for catheter insertion and always work in pairs. So you will have a nurse or you will have a assistant to help you for positioning the patient and for inserting the catheter without any contamination. Practice hand hygiene before inserting the catheter. This is very important so that contamination does not occur. Okay. And when you're inserting catheter, the person has to be wearing PPE. That is, he should have gloves. He should have apron. Okay, and you have to drape the patient. Use antiseptic solution for cleaning the urethral meatus, and use a single-use packet of lubricant jelly so that there is no contamination. So it should be done under aseptic technique, and always choose a catheter which has the smallest feasible diameter so that trauma is not caused for the patient. So this is a picture of a urinary catheter. So you can see that the urinary catheter has a balloon port and a urine drainage port, and through the balloon port, after inserting the catheter, the balloon is inflated so that the catheter does not come out from the patient's urinary tract. Now, once the catheter is inserted, what we have to do, okay, to prevent COTI is the catheter has to be secured properly so that it does not cause any movement or traction. Okay. Number two is it should be a closed drainage system. That is, the catheter will be attached to a urinary bag. So this is a closed drainage system. So once a urinary catheter is inserted to a patient, it will be attached to a urinary bag. Now this should never be opened. Okay. So this drainage system should never be broken. Otherwise, it can cause contamination and it can result in catheter-associated urinary tract infection. Now, if at all you are suspecting any breach in aseptic technique, okay, while inserting the catheter, or if you are seeing any leakages, then you will have to replace the entire thing. You have to replace the catheter and the collecting system. Now, another important thing what you have to remember is whenever you are required to collect urine sample for doing urine culture or any urine test, you have to collect a small sample by aspirating urine from the sample port. Okay, you should not take it from the urinary bag, or you should not try to open the system. Okay, and these urine samples should be sent to the laboratory maximum within 2 hours, and always you have to see that the catheter and the urinary bag is positioned in such a way that the urinary bag is always at a lower height. So there is unobstructed urine flow from the catheter into the bag. And always employ routine hygiene. The perineal area of the patient should always be cleaned every day. So all these should be followed when the person is having a catheter. Now, what is not recommended is routine using of antimicrobial impregnated catheter just for thinking that it might prevent COTI. This is not advised. So routine use of antimicrobial or antiseptic impregnated catheter is not advised. Breaking a closed system for collecting urine sample or for any other reason for moving the patient to the bathroom, this is not advised. Okay, you should never break a closed system. If it is broken, then you have to replace the catheter and the entire system. Okay. Then screening the patient in between to check whether the patient has developed bacteriuria also is not advised, because when you're inserting catheter, some amount of trauma is caused. Okay, and if you take a urine sample of a catheterized patient, invariably it will have some bacteria, but that does not mean that the person is having UTI. Okay, so don't screen a catheterized patient for bacteriuria. And this catheter irrigation should not never be done for COTI. Okay, catheter irrigation is a concept we have heard for preventing CLABSI, but should not be done for COTI. And routine using of antimicrobial prophylaxis to prevent COTI is not advised. Routine changing of catheters is not advised. And alcohol-based products needn't be used on the genital mucosa. It will cause a lot of irritation. So all these practices are not recommended to prevent COTI. Okay, right. Now, this is an example of a COTI bundle. So, if you see in the insertion bundle, the questions asked are sterile equipments or items being used? Is the drainage system closed? After you fit the catheter, is the drainage system closed? Is appropriate catheter size used? Okay, so that you don't cause trauma to the patient. Is strict aseptic technique followed during catheter insertion? And is catheter secured after insertion? So, all these points are asked during insertion. And for maintenance, what they have asked is hand hygiene being followed by the nurse or by the healthcare worker? Is perineal cleaning done? Is closed drainage system maintained? Whether the urinary catheter is secured? Whether the drainage bag is hanging below the bladder, okay, and above the floor, should not be on the floor also. And whether a single glove technique is used while emptying the bag for each patient. So you should not have gloves in both hands, okay, when you're emptying the patient's urinary bag or handling something, because one hand should be free for writing or for any other purpose. The gloved hand will be involved with the fluid or with the infectious material, but one hand has to be free for other purposes. Then use separate container for collection of drainage bag. Okay. So if you want to drain the bag, you should have a separate container, not the container for sending to the lab for assessing urine, assessing bacteriuria. And daily assessment of readiness to remove the catheter has to be done and documented. So this is the daily checklist or the maintenance bundle for COTI. Okay. So with that, we come to an end of our session on infection control bundle. I hope it was clear. So if there are any doubts, I would be more than happy to clear them. Yeah, Shwati, over to you.
Much for such an enlightening session, ma'am. It truly showed your expertise that you have in this area. Let's have some discussion points, ma'am.
Thank you.
So one question that I would like to ask is, while ma'am was discussing about the SSIs, one question that I have for you is that for all the patients, we go with single dosing. So it will be like 2 grams stat or something like that. And also about the redosing schedule. After how many hours should we give a redosing?
Required for most surgeries, because majority of the surgeries will finish in within an hour. Like for example, LSCS, if you say see, it wouldn't even last an hour. Okay, so for such cases, redosing is not required. But for any surgery which is prolonging more than 2.5 or 3 hours, or if you think that there is a lot of blood loss for the patient, so in those cases, then redosing is advised. Okay, and that has to be documented, otherwise it will be missed.
Okay, ma'am. And what about like for all the weight ranges, they go with the single dosing regimen. So what is ma'am's observations on?
You're asking depending on the weight of the patient?
Yeah. Like for all
Yeah,
the
so
patients with
obese
single dosing.
patients will always require a double dosage or a higher dose. If so, that would be better actually to give an increased dose. So that's why always pre-op in the anesthetic visit, we always check the weight of the patient. So this antimicrobial prophylaxis, that's what I said. It is not something which is very strict. Okay, it's not like always second generation cephalosporin has to be given. It varies. Sometimes vancomycin is given. Sometimes ciprofloxacin is given, and uh, the number of dose also varies. Okay, depending on the duration of the surgery and the dose on the.
Thank you for answering that question, ma'am. So one more thing that I would
Yeah.
like to ask is regarding the indwelling catheters. So what is the routine time to change it?
Are you asking about urinary tract catheter?
Yes, the urinary tract catheters, indwelling catheters. What do you say as the ideal time,
Okay,
like
so
14 days?
yeah, so see, the major problem for majority of the consultants in the ICU is when to change the urinary catheter, because we are always confused about that. Now, what IDSA says it doesn't recommend routine change of urinary catheter. Okay, and the concept of changing the catheter after 30 days, that is also very blurry. Okay, so there is no, if you read that, remove the urinary catheter and you put a fresh catheter and take the urine sample for culture. Otherwise, they are not advising any routine change of catheter. They routine change of catheter when there is no indication for antimicrobial impregnated catheter, nor is there any recommendation given for when you need to change the catheter.
Okay, ma'am. So it is like whenever you are suspecting for a UTI or something, you should go with a new catheter and you should send samples
Yes.
from that catheter.
Yes. So remove it, insert a new catheter, and then take the sample.
Okay, ma'am. Thank you so much for your valuable time. It was truly enlightening. Thank you. Thank you all.
Thank you so much. So if there are any further questions if the viewers have regarding the session, you can send it across to me to my email ID or to my WhatsApp. So I'll be more than happy to answer them. Thank you so much, FCPI and Swati and also Vrinda for this wonderful opportunity. I hope uh, it has been very clear. And as I said, I'm looking forward to future sessions. Thank you so much.
Thank you so much, ma'am. Thank you so much.
Okay.